Yeah, probably the one that comes to mind is one from just last week. I had a 40-year-old male that came in. He's a bodybuilder. He also is he does firefighter. And he came in complaining of mild neck pain, moderate to severe anterior lateral shoulder pain with some weakness, and then numbness and tingling and paresthesias in both hands. I'll tell you, prior to doing hands-on diagnostics, I would have been like, oh my goodness, this guy is a train wreck. Where do we start, right? So went ahead, and before starting PT, it just made sense. Let's find out if some of this is coming out of his neck. Let's find out what's going on. And so we did EMG and also ultrasound of the shoulder. Found out he has a partial thickness rotator cuff tear and supraspinatus and tendinopathy of the long-headed biceps. That makes sense for most of our bodybuilders there, Joe. Yeah. He also had, of course, this numbness and tingling in his hands, predominantly in his first, second, third part of his fourth digit, right? And had moderate carpal tunnel problems on the left, but severe on the right. And from our practice standards through the APTA, there's a little bit of a line in there for me when I'm treating. When I get somebody that on an EMG has moderate, I'm going to try to treat that patient because I have fair amount of success with that. Exactly. But once I get into a severe or very severe category, especially with that right hand, the axonopathy that's occurring there, as well as the demyelination in combination, we have a situation that surgery may be more beneficial for that patient. And so we started to talk to a hand surgeon about that. But from a physical therapy standpoint, we said we can take care of the partial thickness rotator cuff tear of the supraspinatus. We can take care of this tendinopathy of the long head of the biceps, and we started care. And we even started care at the wrist, especially on the left, and are just right now consulting with a hand surgeon as to whether they think that physical therapy care is the best move there on the right. But therein lies a little bit more of a differential diagnosis and a plan of care route because of diagnostics that I would never entertain. I would have never had. As a physical therapist, without knowing a grading system for carpal tunnel, or at that point, not even knowing if this was truly at the wrist, perhaps based on some of those sensitivities, specificities for Tunnels versus Sperling, I may have been treating the neck. Well, he has a little mechanical neck pain, but he doesn't have any radiculopathy. And so it would have been really a little more of a crapshoot just to say, where do we start? I mean, you started with some frustration when I'm painting this picture without diagnostics as a PT, and now we just honed in, knew exactly what we needed to treat for the best optimum success for the patient.
And I've heard you on a past presentation stating something about what you are not going to do on a shoulder patient. You keep saying that, so say that one more time.
Well, I'll tell you, I and a lot of our therapists now within our organization, once you do enough musculoskeletal ultrasound evaluations and combined with your orthopedic evaluation of a shoulder, I will never treat a shoulder again without doing an ultrasound. I'll never do that. Before that, partial thickness tear versus tendinopathy versus just an inflammatory process or strain versus full thickness tear. I'll tell you what, there is a wealth of knowledge that comes through that transducer head, through that ultrasound. They can't achieve in any other way unless you are willing to do a $3,000 on MRI on every single patient that walks through your door, which is a disservice to them. Ultrasound is where it's at. I'll never treat another shoulder again without doing an ultrasound, period.